What's up, beautiful people? Another day, another study. Obstructive sleep apnea is something that we treat in the clinic all the time. And unfortunately, it's underdiagnosed. It used to be a lot harder to get diagnosed because we had to send people for sleep studies. So you had to go somewhere. It was weird. I had done one. It was a super weird experience, not a great experience. Now, at least we can do them at home. So it's a lot easier to get people to buy into them and then get treatment for sleep apnea. Now, why is treating sleep apnea important? Sleep apnea is associated with negative cardiometabolic and neurocognitive outcomes. Unfortunately, many people cannot tolerate PAP therapy, and nowadays we have multiple different modalities, masks, nasal pillows. There are implantable devices as well. There are orthodontic devices. So we have tons of therapies. In fact, even GLP receptor agonists are approved for sleep apnea. Now, one of these implantable devices is hypoglossal nerve stimulation, and that was actually approved by the FDA in 2014. However, there wasn't the best quality data previously. Now, this study looked to help fill in some of the gaps and also use proximal hypoglossal nerve stimulation. And this is to stimulate the tongue and the airway muscles. So the tongue kind of moves forward, flattens out, and then also that the airway stay open. So that's the mechanism behind why it helps with sleep apnea. The trial enrolled adults with a BMI of 35 with moderate to severe sleep apnea who could not tolerate PAP therapy. And then all patients received the implant. It's just the placebo group didn't have those turned on for the first 7 months. And then they turned them on after month 7 and then followed both groups again until month 13. So most of what I'm reporting on is that trial period where they compared the people who turned the device on to the people who didn't have the device turned on. Response rate was a 50% or greater improvement in the apnea-hypopnea index, which is what we measure to diagnose sleep apnea. AHI below 20 events an hour was another indication of response. So at 7 months, the AHI response was 58.2% with the treatment versus 13.5% in the placebo group. The median AHI in the treatment group at baseline was 34.3, which decreased to 11.6 at month 7. So that's a significant decrease, enough to drop people down from, let's say, like moderate to mild. So to drop into a different category of OSA. In the secondary analysis, the oxygen desaturation index and the clinical global impression of improvement also improved at 7 months in the treatment group versus the placebo group. And patient-reported outcomes, so that's also something that I like to see in trials to see how patients feel about the therapy. Daytime sleepiness improved in the treatment group, but not in the control group. Similarly, measures of how sleep affects daily life, sleep-related disturbances, and impairment also improved in the treatment group compared to the placebo group. And of note, essentially the respiratory arousals, so waking up in the night due to respiratory issues, essentially resolved with the treatment. And no serious adverse events were reported. There's about 12 surgical reinterventions occurred in 11 patients in the 13 months of the study. So overall, pretty well tolerated. I put limitations down below so you can see those, but it's great to see so many different modalities to treat a condition that's very serious, and finding the one that works for you is important. And sometimes we have to work with multiple different clinicians. We have to work with maybe an orthodontist or a dentist. We have to send people to ear, nose, and throat. We have to send people to, obviously, sleep doctors, and figuring out what's the best way and what's the best modality to treat your sleep apnea.